the first condition that we're going to talk about is bipolar 1 versus bipolar 2. So for the understanding bipolar, it's best to just understand what is the main difference between the two. So the main difference is bipolar 1, you have to meet criteria for a manic episode, whereas bipolar 2, you could never meet the criteria for a manic episode, but you do have to meet the criteria for a major depressive episode. So bipolar 1 has to have mania, does not have to have a major depressive episode. Bipolar 2 has to have hypomania and at least one major depressive episode. So to understand this, you kind of have to understand what constitutes a manic episode. So essentially, it has to last for at least 1 week. And the mnemonic that's used a lot for a manic episode is dig fast. So in order to have a manic episode, you have to have at least 3 of the following symptoms or more. So it would be D, distractibility, I, insomnia, G, grandiosity, F, flight of ideas, A, activity, agitation, or overly ambitiousness, S, sex and spending, or T, talkative. So there has to be presence of at least 3 or more of these symptoms for at least a week. Whereas hypomania, the symptoms last at least 4 days, so not quite as long, and these do not cause impairment, or there's also no psychotic features. So basically the difference is the manic episodes do cause impairment, they do exhibit psychotic features, and last at least a week, whereas hypomania is just a step below. So again, bipolar 1 has mania, bipolar 2 does not. For bipolar 1, some risk factors involved include presence of a major mood disorder, substance use disorder, OCD, can be genetic, and can result from psychosocial stressors as well. One note to just talk about for bipolar 1 and bipolar 2, basically, if there's presence of rapid cycling, which means the quicker that the two, you go from mania to depressive to mania to depressive, the faster it cycles, the worse the prognosis. Bipolar 1 is diagnosed when somebody has 1 or more manic episodes. So after the first manic episode, you are already diagnosed with bipolar 1. Doesn't matter if you've ever had a major depressive episode or anything like that. Once you have 1 manic episode, bipolar 1. So what is the treatment for this? The treatment, first line, would be a mood stabilizer, which the most common one is lithium. So this is commonly used for acute manic episodes as well as maintenance therapy for bipolar 1. Another mood stabilizer that is commonly used is valproic acid, Topamax, Depakote. Again, this is used first line, but it's not as effective as lithium, so lithium is always used first line. The valproic acid is also a mood stabilizer. Second line include second generation antipsychotics, such as risperidone, quetiapine, acenapine, aripiprazole. And just a note that kind of came up on some of my review questions was what can be used in pregnancy. Lithium cannot, and valproic acid cannot, but risperidone can, and other second generation antipsychotics can as well. So another option that can be used if bipolar 1 also occurs with migraines is lamotrigine, which is Lamictal. That was another thing that came up on one of my review questions. A lot of these random notes are stuff that came up on Rosh and Hippo questions that I didn't know and just kind of thought it would be important to add in. The last treatment option for bipolar 1 is electroconvulsive therapy. This can be used if there's an episode of depression with malignant catatonia. So malignant catatonia is basically when somebody holds their muscles in one position and stays there. So it's just some notes on these medications that can be used. Lithium can be toxic, so it has to be monitored in the blood levels periodically, because if they get to a toxic level, here are some things that can happen. It's diarrhea, vomiting, tremor, mild ataxia, drowsiness, muscle hyperirritability or muscular weakness, You also want to avoid using lithium in renal failure, and it can also cause drug-induced diabetes insipidus and leukocytosis. So lithium is a great drug for bipolar 1, but it does have to be monitored because of the toxicity. And then additionally, since we talked about the second generation antipsychotics for bipolar 1, you also want to keep in mind what you have to monitor for those. That is something that comes up a lot in questions too, is things you have to monitor if you're on a second generation antipsychotic. So this includes things like pulse, blood pressure, weight, height, calculation of BMI, fasting blood glucose or hemoglobin A1C, lipid panel, CBC, electrolytes, renal function test, and hepatic function test, and TSH. So although second generation antipsychotics are really good drugs, there is a lot of things to monitor, especially think lipids, think they affect glucose, so those things definitely have to be monitored. So going back to bipolar 2, bipolar 2 is just a hypomanic episode with a classified depressive episode, which will go into criteria for what constitutes a major depressive episode when we get to MDD. But just know bipolar 2 has to have a depressive episode. So essentially the same treatment, long-term maintenance, you want to think lithium or valproate, which are your mood stabilizers. You can also use the lamotrigine, which can be used as a mood stabilizer as well. Second generation antipsychotics as well for second line or adjunct therapy to a lithium or mood stabilizer can also be used. When you're thinking of the valproic acid, again, there are some adverse effects such as hepatotoxicity, pancreatitis, and neurotube defects if used in pregnancy. So again, the lithium and valproic acid you do not want to use in pregnancy. The second generation antipsychotics, especially risperidone, you can. So then also carbamazepine, that can also be used in long-term maintenance for bipolar 2, can cause agranulocytosis and drug reactions. The other big antipsychotic you want to think of when you hear agranulocytosis as a side effect is clozapine. So if you ever have a question about an antipsychotic or a medication that causes agranulocytosis, you want to think clozapine. Also, lamotrigine can cause Stevens-Johnson syndrome, which is that like diffuse body rash, high fever, and like a really bad reaction. So you want to think that with lamotrigine. All right. So then moving on to cyclothymic disorder. So this you want to think is pretty similar to your bipolars. However, you have these chronic fluctuating mood disturbances involving periods of hypomanic symptoms, so like what you would see in bipolar 2, and periods of depressive symptoms, but the depressive symptoms don't quite constitute a major depressive episode. So it's kind of like a step below bipolar 2. You're alternating between hypomania and depressive symptoms, but not quite depression. And that is something that persist for at least 2 years and never separated by at least 2 months. The symptoms can never be absent for more than 2 months. So it's kind of like a underlying, like it's just there all the time, but not quite as severe as bipolar. So mean age of onset for the cyclothymic disorder is about 15 to 25 years old. Can frequently occur with borderline personality disorder, which we will get into when we get to the personality disorders, and can also present with marital or interpersonal difficulties, so difficulties in other areas of life. What you want to look for symptoms is pretty similar to that of bipolar. You want to think that distractibility, the over-talkativeness, the over-ambitiousness, grandiosity thinking, insomnia, things like that kind of constitute more of hypomania, and then alternating with symptoms of depression being down, but not quite an episode of major depressive episode. But you won't have quite all the symptoms involved in major depressive, and it's for a long, extended period of time consistently. The treatment for this, since it's not quite bipolar, It's more mild. You're going to start with just cognitive behavioral therapy, which is a good first line for a lot of these things you're going to see. So cognitive behavioral therapy is the first line treatment for cyclothymic disorder. So now going into major depressive disorder, which we talked about in bipolar 2, you have to have at least one major depressive episode. Major depressive episode has to last at least 2 weeks. Of course, to be called major depressive episode versus bipolar 1 or bipolar 2, you can't have any episodes of hypomania or mania, because then you would be bipolar 1 or bipolar 2. So mean age of onset of major depressive disorder is 40 years old. This is the most common psych disorder in the world. So it is very common. You'll see it a lot, especially in psych. I've seen it a bunch in my rotation. Let's go into the diagnostic criteria. Big mnemonic you'll hear with depressive episodes is SIG-E-CAPS. And basically, you need to have at least 5 of these symptoms for at least 2 weeks at a time to be diagnosed with major depressive disorder. So out of the 5 symptoms, you need to have at least one of these: a depressed mood or anhedonia or loss of interest. So if you're having 5 symptoms of depression but neither of those are present, then it's not depression. But depressed mood is pretty much a hallmark in depression. So other than that, you can have the sleep disturbance. So like I said, the anhedonia or interest lost, guilt, loss of energy, concentration, appetite changes, psychomotor agitation, suicidal thoughts or behavior. So you have to have at least 5 of those symptoms. Again, one has to be either depressed mood or anhedonia. On physical exam, you're going to see people who are just kind of stooped, downcast, talk really soft and slow a lot of times, looking down, things like that. Just think of someone who's sad and what they would look like. And so for diagnosis other than the symptoms, a big one that you'll see is the PHQ-9. Every patient that comes into our office has to answer it. It's like a self-evaluation essentially with symptoms. There's another one called the HAM-D. It's another screening questionnaire. A big thing with a lot of these, especially depression, is you want to rule out an underlying medical cause of these symptoms before you just automatically say, oh, you have major depressive disorder. So you want to rule out some other things such as like your thyroid causing it, possibly anemia. So what you want to do before making this diagnosis is you want to make sure the person has had TSH drawn, CMP, CBC done, pregnancy test, urine drug screen, rule out like a drug toxicity, vitamin B12, and MRI, just to rule out any neurological causes there. Treatment, first line, CBT, cognitive behavioral therapy, like we said, is first line for a lot of things. As far as pharm therapy, SSRIs, that's like your sertraline, paroxetine, fluoxetine. SNRIs, like your desvenlafaxine, bupropion, and mirtazapine. One thing you have to keep in mind if you're starting a patient on the SSRIs, SNRIs, which are commonly used first, it might take 4 to 6 weeks for a patient to see an effect. So you want to just keep that in mind when you're telling patients if they don't see an effect in a week, like don't just stop taking it. You're going to have to keep taking it for 4 to 6 weeks before you get the full effect typically. A couple things you want to keep in mind. So if a patient is also experiencing chronic pain with their depression, SNRIs are really good for that, and as well as TCAs, tricyclic antidepressants. And then if a patient is presenting with either ADD or nicotine dependence with their depression, bupropion is a really good first line treatment. So just a couple things to keep in mind with different comorbids. Another thing you want to think of is that there's a couple of these that do cause weight gain. So mirtazapine and other TCAs as well as paroxetine can cause weight gain, and I know that's definitely a factor for a lot of people. So you want to just keep that in mind when you're prescribing, as well as when you're thinking of bupropion. That medication lowers seizure thresholds, so you want to think of like alcoholics. They already are at increased risk for seizure because, you know, if you like are dependent on alcohol and then start to come off of it, your chance of seizures goes way up. So you don't want to do bupropion in alcoholics. And this medication also does not cause weight gain, which for most people is great. However, you want to consider like if patient has eating disorder as well. You probably don't want to use bupropion because it can actually cause weight loss, and you don't want somebody with an eating disorder to lose more weight. One other thing that definitely comes up a lot is the sexual dysfunction side effect. So SSRIs can cause sexual dysfunction relatively commonly. So in a patient, you might want to start them on an SSRI anyway just to see how it goes. If it does cause this side effect, switching to bupropion or Wellbutrin, which is the brand name, is typically the choice because the bupropion does not cause the sexual dysfunction as much as the SSRIs, SNRIs. That's major depressive disorder. That's a huge one. The next one is similar, and this one is persistent depressive disorder or dysthymia. So remember we had cyclothymic disorder, which was kind of like that, not as severe, but for a really long time. This is the same thing, but with just depression. So persistent depressive disorder is, the definition is depressed mood for most of the day for more days than not for at least 2 years, and it's never absent for more than 2 months. So just basically, major depressive disorder, you might have 2 or 3 episodes a year where like for 2 or 3 weeks you're just depressed, but then you get better and you're at baseline again. Well, persistent depressive disorder, you're just in this chronic state of like depression for at least 2 years. Things that can cause this are similar to MDD, like biological, social, psychological factors, can be genetics or prior mental illness. Like how cyclothymic relates to bipolar, this is, like I said, relating to MDD, it's just less severe. So instead of needing 5 symptoms like you need in major depressive disorder, in this one you only need 2 of the following. So 2 of the following symptoms at least: appetite change, sleep changes, lower energy, lower self-esteem, poor concentration, feelings of hopelessness. You need at least 2 of those persistently for 2 years to be diagnosed with persistent depressive disorder. You want to do the same type of workup as you would do with major depressive disorder, just to rule out any underlying medical causes. And treatment for this is pretty similar to that of major depressive disorder. You want to start with CBT and then your SSRIs and SNRIs. So one note I did put on here, I did have some questions on one of my practice tests that had a lot to do with like brain anatomy and what part of the brain is affected in what, condition. So just note that long-standing depression can lead to a decrease in the volume of your prefrontal cortex. Another thing to know that I had no idea about is if you're looking in adolescence or younger, so say you have like a 15-year-old who's having these symptoms, you only need to have symptoms consistently for 1 year versus 2 if you're diagnosing this in adolescence. So moving on to the next one, we got generalized anxiety disorder, GAD, another super, super common one. You're going to see this a lot as well. Definition is a mental disorder characterized by continuous and uncontrolled worrying without a significant cause. And the average age of diagnosis here is the 20s to 30s. Females are affected more than males, and this can be caused by a bunch of things: stress, genetics, just environmental factors, etc. So the mnemonic we learned to memorize the DSM-5 criteria for generalized anxiety disorder is "and I crest," and basically this is the criteria. So the first 3 things that I'm going to say have to be present in order for somebody to be diagnosed with this. So they have to be anxious more days than not, they have to have no control over their worry, and it has to have a duration of more than 6 months. So if this has happened for less than 6 months, not quite generalized anxiety disorder. It has to be occurring for more than 6 months. Moving on to the other criteria, so then you have to have at least 3 or more of the following symptoms: irritability, concentration impairment, restlessness, energy decreased, sleep impairment, and tension in the muscles. So if a patient presents basically very anxious all the time, this has been happening for over 6 months, they can't control this worry, they're irritable, not able to concentrate, not able to sleep, they're restless, muscle tension, this is generalized anxiety disorder. On physical exam, some things you could see are tachycardia, dyspepsia, hyperhidrosis, cold extremities, and a visible tremor. If things like that are happening, you of course want to rule out your underlying things, your anemia, your thyroid, all the other hormone, vitamin deficiencies, and things like that. So you do want to do a pretty extensive workup before you just say, oh, you have generalized anxiety disorder, because there's a lot of things that can present like this medically. So you do want to make sure you're ruling things out before you just say that this is what they have. One screening questionnaire that's commonly used for generalized anxiety is called the GAD-7, and another one is called the Beck Inventory. So if you have any things like that pop up, those are some screening questionnaires for GAD. So again, first line for GAD is cognitive behavioral therapy. For pharm therapy, it's similar to MDD. You're going to do your SSRIs, your SNRIs, and then the dose for anxiety, if you're giving a patient SSRI, SNRI, is lower than the dose you would give for major depressive disorder. So that's kind of use the same medication but different dosages. And then second line, you can use buspirone. You can use second generation antipsychotics. You can use benzodiazepines and anticonvulsants such as gabapentin, pregabalin. Not used quite as commonly, but yeah, again, the SSRIs and SNRIs are the big ones you definitely have to know. And again, here's a little brain anatomy type of pathophys for you. So basically, the increased fear and anxiety is associated with an increased activity in the amygdala. So when you're seeing disorders such as generalized anxiety disorder, panic disorder, PTSD, you want to think increased activity in the amygdala. So you can think amygdala starts with an A, and so does anxiety. So if that helps, I'm all about the memory cues. Alright, so moving on, we've got panic disorder. Panic disorder is diagnosed after at least 2 uncued panic attacks have occurred, followed by at least 1 month or more of significant concern about future attacks, worry about their implications, or a major change in behavior related to these attacks. So basically, panic disorder, you have a panic attack, and then after the panic attack, you're preoccupied for a really long time about having another one. This happens more commonly in females than males. Average age of onset is 30s, and then contributing factors include genetics, anxiety, and abuse in childhood. So to memorize the symptoms of a panic attack, the mnemonic we learned was students fear the 3 C's. So in this, you have to have at least 3 of these symptoms in order to have a panic attack. So the symptoms include sweating, trembling, unsteadiness, derealization, depersonalization, excessive heart rate, nausea, tingling, shortness of breath, fear of dying or losing control, and the 3 C's are chest pain, chills, and choking. So a patient has to have at least 3 of these symptoms in order to have a diagnosed panic attack. Physical exam, you would see tachycardia if they're having an active panic attack. You would see like diaphoresis and just trembling and things like that. But that's if they're having an active panic attack at that time. So as far as diagnosis, again, you want to rule out other conditions, like we said, in anxiety and depression. Like, you want to make sure there's no other underlying medical cause that's causing these attacks. And then the DSM-5 criteria for diagnosing panic disorder is basically recurrent unexpected panic attacks. So there's not like a specific thing that's causing these panic attacks. They usually just come on like randomly, unexpected. And then after a panic attack, you have to have at least 1 panic attack followed by over a month of persistent worry about having another attack or changing behavior to avoid having an attack. So say like somebody had a panic attack last time they went to the grocery store, and now like for the next 2 months they like refuse to go to the grocery store because they think that's what caused it. So things like that. And then disturbance is not attributable to a substance or medical condition. Like we said, you want to rule out underlying causes. and the disturbance is not better explained by another mental disorder. Okay, so the treatment for panic disorder, first line CBT, CBT, CBT. Just know cognitive behavioral therapy is, if that's a choice, it's probably the answer because it's literally first line for almost everything. And so then for an acute attack, if somebody's like having an acute panic attack and say they're, somewhere that they need to like be able to calm down quickly, usually the treatment for that is a benzodiazepam. Such as clonazepam or alprazolam. Those are more faster acting benzodiazepams. And then for chronic management, first line is SSRIs such as fluoxetine, paroxetine, sertraline. And then there's also imipramine or venlafaxine, which is an SNRI that can be used just for chronic management to kind of reduce that like over anxiety about worrying about I'm gonna have another panic attack. So just a couple notes on panic disorder. So panic attacks typically will come on abruptly, out of nowhere, last about 10 to 15 minutes. That's kind of the average. And substances such as caffeine, cocaine, or amphetamines can precipitate panic attacks. And then panic disorder is associated again with the hyperactivity of the amygdala and the hypothalamus. So remember, we're thinking anxiety, fear, amygdala. So then we go into specific phobia, phobic disorders. So these are marked persisting fear or anxiety about a specific object or situation for greater than or equal to 6 months. So common stimuli for this involve animals, natural environments such as heights, storms, water, or blood injection injuries such as needles or invasive medical procedures, or situational situations such as like traveling on airplanes, being in elevators, being in enclosed spaces. So when you're thinking of phobia, you're thinking of somebody is specifically fearful of one thing, kind of. In this sense, there's fear and anxiety about a object or situation, and persistent avoidance or trying to avoid that specific situation or thing, and basically the fear that someone experiences out of proportion to the danger of the actual thing. So like they're extremely afraid to go on an elevator when in reality elevators are generally pretty safe. So some of the symptoms people experience in response to their like trigger phobia would be things like blushing, sweating, trembling, increased heart rate, dry mouth, difficult swallowing, fasciculations around the eyes, nausea, diarrhea, rigid posture, avoiding of eye contact. So they're just very fearful of, their one thing, which is why it's called specific phobia. So it's not really generalized, it's a specific thing. Things that you can do for diagnosis, you can do a psych assessment of them, or there's something called a social phobia inventory where it's more like a screening questionnaire like what we were talking about earlier. And treatment for this first line is CBT and exposure therapy. So we watched this one video in didactic year where there was this guy who was just terrified of dogs, and for his exposure therapy they like brought a dog around him. The dog was super nice and he was like terrified. I wouldn't look at it, like was trying to run away, was like crying, and like this big muscular guy. And eventually like they slowly introduced the dog to him like over time and had him, pet the dog, and then they had him like feed the dog, give the dog a treat, and like slowly kind of expose him to his fear to get him over the fear. Again, short-term, short-acting benzos can be used for like acute situations, like say somebody has to fly to go somewhere but they're like horrified, then a benzodiazepine can be given for that. However, you want to make sure that they don't have any history of abuse of any substances because, again, benzos are very addictive and high risk for dependence and abuse. And in specific phobias, antidepressants are not recommended here unless they also have like major depressive disorder or something like that, but just in general they're not recommended. So the last one would be PTSD, post-traumatic stress disorder, and this is a psychiatric disorder associated with development of characteristic symptoms after exposure to a traumatic event that leads to significant distress or functional impairment. So basically, the risk factors here are basically exposure to a traumatic event. So let me just go through the DSM-5 criteria here. There's quite a bit involved, but it makes sense when you kind of think it through. So first criteria, exposure to an actual or threatened death, serious injury, or sexual violence. A lot of times when I think of PTSD, I think of military, which is super common in military, but even more common are, patients who undergo like abuse in childhood, sexual abuse, domestic abuse in marriage, things like that. So then the second criteria is at least one intrusion symptom associated with and occurring after the event. So basically, after the event happens, they have to have intrusion symptoms such as flashbacks, nightmares, things like that, where they are brought back to the event. And patients I've talked to that have this say that they're very, very realistic, these intrusion symptoms. And so this is definitely something that is required for a patient to have in order to be diagnosed with PTSD. The third criteria is persistent avoidance of certain stimuli associated with the event. So a common one that I hear here is like for patients or ex-military, they typically would like to avoid large crowds because that could be a trigger for them. That's one example of like people wanting to avoid large crowds in order to not be triggered for their PTSD symptoms. Another one would be like for patients who were sexually abused, to avoid certain things on social media and movies that might trigger them in that way. So that would be the third criteria. The fourth criteria is negative changes in cognition and mood associated with the event. So some examples of these negative symptoms include either just like a numbness or a sadness. The next criteria is changes in arousal and reactivity beginning or worsening after the event. So this is like someone that's always on guard, like say something happens or someone drops something, and it's kind of loud and startling, and most people are like, oh, but like maybe for someone with PTSD who, that sound is like almost triggering, like would really react like a big reaction versus just like oh, something fell, so just like always being on guard and like reacting like a lot to certain things. And then the last criteria is that the previous criteria must be met for more than 1 month after the event. So like say the event happens in January and then throughout February they're having these negative symptoms, hyperarousal, but then like everything kind of chills out and goes away, then it's not PTSD. But if the symptoms persist longer than a month, then that's criteria for PTSD. So treatment for this: first line psychotherapy, second line or in conjunction with psychotherapy, your medications, SSRIs and SNRIs such as venlafaxine. The only two FDA approved SSRIs for PTSD are sertraline and paroxetine. So others can probably be used off label, but like when you're thinking of actual FDA approved, sertraline and paroxetine. And then the last one that you want to keep in mind for PTSD is prazosin, which is used for nightmares related to PTSD. So if a patient is having persistent nightmares that are keeping them up, prazosin is the medication you want to think of. This one almost definitely will likely come up on a question. And also came up very early, like the second day of my rotation, I was asked this and I did not remember prazosin. So prazosin is used for nightmares related to PTSD and think like insomnia and etc. So those are the major big ones. We're going to take a little stop here and go from there.